Hello, everyone, and thank you so much for joining us today. My name is Amanda Atkinson, and I'm excited to welcome you to this special patient session of the COPD Foundation's Lung Collaborative Assembly. This session is focused on COPD and some new treatment options that many people are starting to talk about. We will be discussing biologics. We're honored today to have Dr. David Mannino with us. Dr. Mannino is co-founder of the COPD Foundation, professor of medicine at University of Kentucky, and a leading expert in lung health. He's dedicated his career to helping patients live longer, fuller lives with better understanding and giving cutting-edge care and education. Today, Dr. Mannino will share with us what biologics are, how they work, and what they could mean for people living with COPD. After his talk, we'll have time for your questions, so please jot them down as you go. And let's give a warm welcome to Dr. David Mannino. Welcome, Dr. Mannino.
Great. Thank you so much, Amanda, for that very kind introduction. And yes, and we are in very exciting times in the world of how COPD is treated because in the past 2 years now, we've had several new therapies that have been approved by the U.S. Food and Drug Administration for the treatment of COPD. Including two new biologic therapies that I will be talking about in more depth today. And we're just so pleased because really in the past 20 years, there really have not been new types of therapies for the treatment of COPD. So we are very excited and hopefully that this will lead to additional therapies being approved in the coming years. Next slide, please. Can we advance the slide? There we go. And this is me, and these are my potential conflicts of interest. I basically serve as a consultant for any company that is looking at COPD therapies as they're interested in how this might both affect outcomes and be helpful to patients. Next slide, please. So what is a biologic therapy? And this is a different class of medication. Most of the medications that we've had for many, many years, really up until perhaps the past 20 years, had been what are called small molecules that basically affect how certain pathways in the body function. Biologics are different in that these are larger molecules, and these are frequently immunoglobulins. That immunoglobulins are basically these proteins that are developed by white blood cells in our bodies to help fight infections. But they can also be engineered to target very specific proteins that then become useful in what are these very targeted biologic therapies. And these, in fact, end up targeting very specific types of inflammation. As all of you hopefully are well aware that inflammation is an important part of what happens in COPD and what leads, for example, or results in exacerbations and results in bad outcomes. And for many years, our main way of treating inflammation in COPD has been with the use of corticosteroids, such as prednisone or solumedrol or medrol. Unfortunately, while steroids are wonderful in their ability to fight inflammation, they have a lot of side effects. And for anybody that has been on steroids, particularly if you've been on them for a longer period of time, anything more than 4 or 5 days, and they have side effects that include swelling, fluid retention, thinning of the skin, decreased ability to fight infections. So there's a lot of downsides of these systemic steroids. And basically, what we have attempted I always say one of the holy grails in the treatment of COPD and other chronic inflammatory disease is to find a therapy that has the benefits of systemic steroids without the side effects. And that is, in fact, what has been happening over the past several years, both in the world of COPD and asthma, and also in other parts of the world of medicine, such as inflammatory bowel disease or rheumatoid arthritis or the like. Next slide, please. So, who are the patients that we identify as potentially being able to benefit from biologic therapies? Well, the most important thing is that patients who have COPD who are not responding to their current therapies, they're still having a lot of symptoms, or they're continuing to have exacerbations despite being on maximal therapy. So this is, and when I discuss this with patients, this is critical. If a patient is doing well on their current therapies, there's no reason to change them. However, if they're not doing well on them and they're continuing to either have any symptoms or exacerbations, and then that's a person that we look at other options for. And currently the two biologic therapies that I'll be discussing in subsequent slides that we have available in the world of COPD, have very specific criteria, and it's important to understand that they do not work for everybody. They don't work for everybody with COPD, and it's typically one for the two current therapies that we have available. They target a very specific type of inflammation, and that's called eosinophilic inflammation. Eosinophils are some of the white blood cells in the body that respond they're basically involved in allergic response. So, for example, in people with COPD, it's probably somewhere between 20 and 40% of patients have this type of eosinophilic inflammation and would even qualify for this type of therapy. In the world of asthma, this proportion is higher. It's probably in the 50 to perhaps 70% range. But in patients with COPD alone, this proportion is lower. And this is important because in clinical trials that have been done in patients who do not have this eosinophilic inflammation, and they just do not respond to this type of therapy. So, and as I'll mention later, every therapy has the potential for side effects. So one is always trying to balance effects and benefits of therapy versus the side effects of that therapy. And if you don't think that there's going to be much of a benefit, then it really isn't worth putting people in therapy because of the risk of side effects. Next slide. And so the two therapies that have been approved are listed here. Dupilumab, also known as Dupixent, was approved about a year and a half ago for the treatment of COPD. It actually had been used in other diseases such as asthma and allergic dermatitis and sinusitis with nasal polyps. Has been approved long ago, just recently approved in COPD. And mepolizumab, also known as Nucala, was recently approved for COPD, and this had been approved for use in asthma for at least 7 or 8 years now, and is very effective again in subtypes of patients with asthma, and similar effectiveness in patients with COPD, again, who have this eosinophilic or allergic type of inflammation. Dupilumab is an injection that is given every 2 weeks, and mepolizumab, Nucala, is an injection that is given every 4 weeks. Next slide. And for these current therapies, as noted, and they are administered via a shot, and typically what happens is that the initial dose is administered in the physician's office, just to be sure that the patient doesn't have side effects, and then after that, and it can be administered at home. the way this is administered, a person can either administer it to themselves, and they actually have, now, for some of these therapies, they have what are called self-injectors. So they're relatively easy to use, or they can be administered in a more traditional way. But again, one of the things that we are currently noticing is that patients, with the advent of other types of injectable therapies, such as some of these newer diabetes therapies, the patients are becoming more accepting and more comfortable with administering medication via injection, particularly for the ones that only are they're used once a week or once a month or so. So, and these medications fall in that class. Next slide. Um, what are the cost of these therapies? And these are more expensive therapies than our typical COPD therapies, or at least therapies to date. And most of our therapies for COPD have been inhalers, a few oral pill options. But the biologic therapies tend to be more expensive. And as such, insurance companies, or we call them payers, tend to put more restrictions on them. They want to be sure that patients who get these are ones that would really benefit from this type of therapy. And in some cases, depending what type of insurance patients have, there may be co-pays that patients have to come up with to access these therapies. And in certain instances, some of the companies that make these therapies have patient assistant programs available. Although generally, if a person is on government insurance such as Medicare or Medicaid, that's not an option available to them. But again, every insurance coverage is different. And I know at our clinic at the University of Kentucky, we have a pharmacist in our clinic that works with patients and their insurers to be sure that patients have access to these therapies. Next slide. It's important to understand that these are not fast-acting medications. If a person is having acute worsening, and you can't expect that this is a medication that would work in that situation. So they take time to work. Not all patients respond to biologic therapies. That there are some patients that benefit from these, and others that do not. So we always are trying to do what we can to ensure that patients have the highest likelihood of actually being able to respond to these therapies. The main goal of these therapies is to reduce exacerbations or flare-ups. So this is important. Although several of my patients who have been on these types of therapies have actually had improvement in their symptoms, and at least in some of these therapies, there has been a demonstrated improvement in lung function. So, but again, every patient is different, and what one person may experience may not be experienced by other persons. These medications, as is true for all medications, have the potential for side effects. And the most common side effect is what we call local administration reactions. And that's basically soreness or a local reaction at the site of the injection. Although other ones are listed here. And in fact, some of our patients on the COPD Foundation website who have been on these therapies have actually had to stop because of side effects such as headaches or joint pains. So that is important. And again, that is why when we put a patient on one of these therapies, we want to be sure that to the best that we can, that they are a patient that will in fact be responding to this type of therapy. But the other potential side effects are noted on this slide. Next slide. At this point, we have left lots of time for questions and answers. This is actually something that is measured as part of a routine blood test. We get patients frequently get blood tests, and actually now in our pulmonary clinics, in my clinic, I'm checking these blood tests more and more. But if you get what's called a complete blood count with then a differential, that a complete blood count tells you how much hemoglobin and what your hemoglobin hematocrit is. So that basically is how many red blood cells you have, and which relates to whether you have iron enough iron in your body, but also gives you a white blood cell count. And white blood cell counts, white blood cells come in several different varieties. Neutrophils are the ones that mostly fight infections. Lymphocytes produce immunoglobulins and also help fight infections. And then eosinophils are the ones that are more common in allergies. So if a person has elevated eosinophil counts, which can be measured on a blood test, and the typical, most of the studies that have looked at this use an eosinophil count of 300. In the label for most of these therapies, they don't put a specific number in there, but they talk about an eosinophilic type of inflammation. Now, we're finding that most insurance companies, that before they approve this type of therapy, they want to see an elevated eosinophil count. And typically, 300 is where most come down. I've seen some be approved at a lower count of 150 because that was used in some of the clinical trials. I haven't noticed, or I have not heard that and right now the dupilumab is injected every 2 weeks, so there's I guess more potential for injection reactions, just because you're getting injected more frequently. But at least from the data I've seen and what I am hearing in our clinic, that that I haven't heard of a difference between those, and um, and the proportion of patients, both in clinical trials and what we've seen in our clinic, that have to stop because of side effects is small. It's been less than 15 or 20% in our experience. Now, and it's possible that as these get more widespread use, that proportion may change. But again, and I've seen that pretty much any time a person starts on a new medication, there's a risk of side effects, no matter what that medication is, and that's something that we just uh, you know tell patients about, and if something happens, that we regroup and try something else. Yes, and actually we recommend that our patients with COPD that they get vaccinated to as many things as possible. Not only influenza and COVID, but pneumonia, shingles, RSV. The and most 80% of COPD exacerbations are related to infections, with a large proportion of those being viral, a small proportion being bacterial. But so anything that you can do uh, to beef up your immune system, to increase your likelihood that you can fight off those infections, and that's really what vaccinations do. That we strongly encourage that. Yeah, generally, um, um, yes. That if you do fine with the first one, you should do fine, and of course, and there are always exceptions to that, but at least the way I've seen the way this works in our clinic is that if you do okay with the first one, then you're allowed to administer the other ones at home, and similar for and dupilumab, but again. Uh, does it absolutely guarantee that you won't have a reaction in the future? No, it's nothing is ever guaranteed, but certainly I think the risk is much lower.
Right now, the two biologic options that are available for patients with COPD are for those patients who have a elevated level of eosinophils, or these allergic responding white blood cells in their blood. And that corresponds to somewhere between 15 and maybe 30, and perhaps as high as 40% of patients with COPD. So it's not for all patients. And this can be contrasted in the asthma world. It's a much higher proportion, perhaps as much as 60 or 70%. If a COPD patient is continuing to having symptoms or exacerbations, despite being on appropriate therapy and using those therapies appropriately, um, that at that point, it is worthwhile at least having a conversation with your clinician and to see. And the first step in this process actually is to get a measurement of your blood to see if you would actually even qualify for these types of therapies. Because as I had mentioned in another response, more than half of patients with COPD wouldn't even qualify for this type of therapy, and it's probably only it's maybe in that 20 to 30% range of patients with COPD who would qualify. And then there is some additional steps that if you do sort of meet that threshold, and then there's the issue of seeing whether the current therapy you're on would be appropriate to add this on to, and also to see whether the insurance covers that you have would actually cover this, because depending on the type of insurance people have, there may be high copays associated with this. For the therapeutic options that we now have available, and I mentioned previously, there are two of them. Both are injections. One is administered every 2 weeks. The other is administered every 4 weeks. And typically what patients are doing, what physicians are doing, is they administer the initial dose in the office just to be sure that a person doesn't have a reaction to it. And the reactions are very rare. The most common reaction is just a sort of a local reaction at the site of the injection, which is fairly common with most injectable therapies. But then if the patient does well with that, then follow-up doses can be administered in their home. Yes, as I mentioned in the talk, these therapies do not act immediately. So they don't make you feel better in the short term, as we've seen, for example, with some of the inhaled therapies that we have. However, at least in my patients that I have put on this, when they come back to see me at their follow-up visit, for those that have responded, they say, "Oh gosh, that's I've noticed that I am feeling better with this." Or the other thing, the other rationale for using these therapies is to decrease these exacerbations or flare-ups. So to restate that, and you should not expect an immediate improvement, but for patients that do respond, sometimes when they come back again, they report that either their symptoms are less, or they feel like they're able to do more. So that's a good response if that does occur. Yeah. Right now, and these types of therapies are being added on to the other existing therapies that patients have. So if you're on a maintenance inhaler that you're using once or twice a day, or nebulized therapy, this is in addition to that. Now it may be that at some point in the future that that patients may, if they have an improvement, may be able to back off on some of their other therapies. And the therapies that I'm most interested in backing off on are these short-acting therapies that people are using either with little meter dose inhalers or a nebulizer. Because my goal for those is the less of those that can be used, the better. But right now, we continue to maintain patients on their various maintenance therapies.
Well, thank you so much, Dr. Mannino, for sharing your time, your experiences, and insights with us today. This was a very clear presentation and a really hopeful look at to where COPD treatment's headed, especially with all this exciting progress in biologics. And so we want to thank everyone who joined us today. Conversations like this just remind us that knowledge and connection are powerful tools for living well with COPD. Please also visit the COPD Foundation website. And remember, join COPD 360 Social to connect with others, ask questions, and stay up to date on the latest in COPD care. So, on behalf of the foundation and our team, we thank you again for being part of today's session. Everyone, have a wonderful day. And thank you again, Dr. Mannino.